All right, this PowerPoint we're talking about cellular regulation. We're going to start with the antibiotics. Actions of anti-infectives, they'll either be bactericidal or bacteriostatic. Bactericidal just means that they kill the cell, and bacteriostatic means that they stop replication. Narrow spectrum just means they're only effective against a few microorganisms, whereas broad spectrum means they treat a wide variety of infections. An example of broad spectrum would be like augmentin, cephalosporins. These are good against a lot of different infections, whereas something like clindamycin is narrow spectrum. Oftentimes we'll start with a broad spectrum because we don't know exactly what's going on or what the bug is, and it's going to take us a while to find out. So they'll start with a broad spectrum that is commonly used for whatever type of infection that you're presenting with, and then after the culture and sensitivity comes back, they'll usually move you to a narrow spectrum if something has been proven to be more effective, or if, say, the broad spectrum isn't working but as well as they wanted it to, but they found a narrow spectrum that does work against the bacteria that's been grown, they'll move you to narrow spectrum. All right, signs and symptoms of infection. It just depends on the type of infection, where it's at. Of course, pain, fever, redness, swelling. If it's a skin or mucous membrane infection, that's when you're going to see the redness and swelling a lot of times. If it's like a urinary tract infection, of course, the pain is going to be with urination. You'll also see fever, high white count. With the elderly, you'll see changes in level of consciousness. You'll see that a lot of times before they complain of any pain. In fact, a lot of times they don't even complain of pain with urination. They have that change in level of consciousness. It could also be pneumonia that will cause the change in level of consciousness, especially in the elderly. But you just got to think about where the infection is, and that will correlate with our signs and symptoms. And as far as how we check to see that the antibiotics are working, of course, now we're going to look and see, are the signs and symptoms getting better? If their signs and symptoms were, lots of congestion, difficulty breathing with pneumonia, are they getting better? Is their breathing getting better? If it was, painful urination, is that getting better? If they had a fever, has the temperature come down? And then, of course, we could look at white count. Is the white count getting better? Resistance. This is, as far as resistance goes, we're talking about the resistance of the bacteria to the antibiotics. There's two ways that bacteria are resistant. They're either naturally resistant, meaning whatever enzyme system that the antibiotic works on to kill or stop growth of that bacteria or microorganism is not affected, or that the microorganism in question is not affected by that. Let's go with gram-positive and gram-negative bacteria, right? They have different cell walls. Some antibiotics are only good at destroying the cell wall of a gram-positive or gram-negative bacteria. Therefore, if it's only good at destroying gram-positives, then gram-negatives naturally are resistant to the antibiotic. Whereas acquired means at one point that microorganism was affected by the antibiotic, but somewhere along the way, the bacteria evolved a resistance to that antibiotic and is no longer affected by it. That's the one that we're really worried about, right? If they're naturally resistant, they're naturally resistant. But them being able to acquire resistance is concerning because that's limiting the available drugs we have to fight or combat these microorganisms. You're seeing this, of course, with MRSA, VRE, C. diff, all these so-called superbugs that are resistant to multiple antibiotics because we've used them so much. We use them ubiquitously, not just for our health purposes, but for the health purposes of animals. And not only the health purposes of animals, but we use them in agriculture to help animals grow, right? You see them in cattle and poultry industries to help promote growth, and to prevent their livestock from dying from infections. And it makes sense, except unfortunately what it has caused is a lot of bacteria are just no longer affected by these medications anymore. They've acquired a resistance. So let's talk about how we can help with that. So how can we help with preventing resistance? There's a few things we can do. The big thing, of course, is patient teaching. Teach them that the drug is for the infection they have now. It's not to be used to treat other infections. So don't save your med. Okay, you take it until it's gone. Don't just take part of it and save it, which unfortunately you see all the time. Take it exactly as prescribed. The number of times that the doc tells you to take it a day and the number of days he tells you to take it. Do not stop don't stop taking the medicine just because you're feeling better. You're going to start feeling better. Anybody that starts taking an antibiotic for an infection is probably going to feel better in 24 hours, 48 hours, well before the antibiotic is fully run, right before we're done. They may feel like $1 million within 4 or 5 days, but yet they got another 4 to 6 days left on the antibiotic. It's common for people to stop using it. The problem with that is there's still bacteria in there. And if we're not fully getting rid of that, the potential for them to become resistant to that antibiotic increases. Another thing we can do, of course, is just try to prevent the spread. If we can prevent the spread of microorganisms, then we don't have to treat as many infections. That also will help prevent resistance. We all know about isolation precautions, and that's good. We don't want those drugs that are already resistant to get out there and become even more resistant. So we definitely will do that, but also just standard precautions and basic precautions we take, right? Washing our hands regularly, wearing gloves whenever we're coming into contact with potentially infected materials. Those types of things we can also do. If we can help prevent infection, we can help prevent resistance. Let's talk about the culture and sensitivity. I talked about that a little bit earlier with narrow and broad spectrum. A culture just identifies whatever the organism is. It just identifies the organism. Whereas a sensitivity will tell us what medications are capable of controlling or defeating that organism. It takes about 3 to 5 days to get the final results. And like I talked about earlier, this can help us identify the drugs, obviously, that are most useful in it, and it can even identify if there's some narrow spectrum medications that might be more useful. So that's what we use these for. And again, it typically takes about 3 to 5 days. However, a lot of times docs will get some preliminary results, especially if the patient is just not responding and it's getting worse. They may look at those preliminary results and say, well, let's try this one. There doesn't seem to be any growth anywhere near this medication yet. I have certainly seen that occur. There are some times when we use antibiotics for prophylactic reasons. Not nearly as much as we used to. We used to use them a lot for prophylaxis. But there's still a few instances where we use them. Surgery is probably the most common. If you've ever had a surgery or know a loved one that's had a surgery, it's very common for them to get a round of antibiotics either prior to, or usually prior to surgery. Actually, that's the CDC, or I'm sorry, the Health and Human Services recommendation. But and then we can have them for a little bit after surgery as well. It all depends on the type of surgery, of course, as as far as how much antibiotic, what antibiotic, and for how long they're going to give it to you. But for as far as the U.S. Department of Health is concerned, they say the best or the most optimal time to give an antibiotic for prophylaxis before surgery is 60 minutes before the surgery, and then for no more than 24 hours after the surgery. Now, of course, if there was already infection involved, then they would go longer, but this is for basic surgery or surgery where there's not already infection involved. They recommend, again, 60 minutes before surgery and then no more than 24 hours post-op. Sometimes we use prophylactic antibiotics for travel. It used to be we would give these to people that were going to high-risk areas. Now it's not necessarily everybody that goes to high-risk areas. Now it's the high-risk patients that go to high-risk areas. And even then, a lot of times they'll tell them not to start taking them until they start showing signs and symptoms of infection. Like Shigella or Campylobacter, these different types of like traveler's diarrhea type of infections that people get. Some people are more at risk for those, and of course they would, but they still don't want them taking the med until they really start to show symptoms of it, and then start taking the med. And then we do it for invasive procedures for patients that have had any sort of cardiac valve disease or cardiac valve replacement. These guys they have a risk of endocarditis, valvular disease. They're going to take antibiotics before any dental procedures, any procedure that's going to potentially cause bleeding. They're going to need to take prophylactic antibiotics for. So, of course, anybody with history of valvular disease or replacement valves, or even a history of endocarditis, they're going to have to let their dentist know, let anybody that's going to do any sort of procedure on them know that they have this history, and then follow their recommendations as far as prophylaxis is concerned. So just a little bit of information about antibiotics. We talked about this a little bit already, but just a little review there. There are different classes, and they each have their own sites of action on the bacterial cell. We'll go into that a little bit. What I'm mostly concerned with is you getting to be familiar with the different antibiotics, what's important as far as nursing considerations, because each antibiotic class has its own special considerations that we need to look at whenever we're giving these meds. Every antibiotic comes with some basic stuff we already talked about, right? We're going to teach them, take all the medicine exactly as prescribed. Don't stop taking it just because you're feeling better. We know that a lot of medications can cause GI upset, especially those broad spectrums. We know that they all potentially can have the risk of superinfection, but especially the broad spectrums. We know that it's probably a good idea to increase fluids while we're on antibiotics, but each class has some more specific nuances that we need to worry about, and we're going to talk about those now. Let's talk about our classification first. Gram-positive, it simply means it does not hold, or I'm sorry, this one holds the Gram stain. Gram stain is a type of test that they do to quickly identify bacteria into two classes, gram-positive, gram-negative, which is good because it's a quick test and it gives us information that we can use to choose an appropriate antibiotic. It's not nearly as specific as a culture and sensitivity. However, it is good information, especially early on. We can get this much quicker than a CNS. Gram-negative just means that it does not retain the Gram stain. Gram-positive, a lot of times respiratory, soft tissue infections. Those are the more common gram-positives, whereas gram-negatives a lot of times are GU and GI infections. Then aerobic just means it depends on oxygen for survival. So think about bacteria that we find on our skin or in our respiratory tract, those are aerobic. Whereas anaerobic do not use oxygen, so these can be like lower in the gut, like C. diff, C. perforans. There's others as well. But all right, now let's talk about the different classifications of meds. Gentamicin, streptomycin, these are aminoglycosides. These are for serious infections. The way they work is they inhibit protein synthesis and they cause cell death, so they're bactericidal. We use them to treat serious infections caused by susceptible gram-negative aerobic bacteria. And again, these are for serious infections. Adverse effects. There's a potential for some hypersensitivity. There's even a little potential maybe for some respiratory depression, so we'll be careful with that. These have that narrow therapeutic range, so we're watching lab levels on these, and their toxicity can result in ototoxicity or nephrotoxicity. So we're going to really watch for that as well. So be careful in people with renal impairment and hearing loss, and those are the assessments that we're going to make as well. Interacts with loop diuretics, which makes sense because those also have the nephrotoxic, ototoxic potential. And then also neuromuscular blockers. Patient teaching, they're going to need labs to monitor their levels. We're going to help them or encourage them to increase their fluid intake. And then the normal stuff, take all prescribed doses exactly as directed. Carbapenems, it's your ertapenem, meropenem. These inhibit cell wall membrane synthesis, so again, bactericidal. They're broad spectrum. We use it to treat a lot of infections, gram-positive, gram-negative. However, they're still primarily used for serious infections, usually like serious UTIs, serious skin infections, bone and joint infections. So they are broad spectrum, but we're still at this point using them for serious infections. Adverse effects, they're broad spectrum. So we know that increases the risk for GI distress, like diarrhea and superinfection. Be careful in people that already have an allergy to penicillins or cephalosporins. There's a potential there for some cross allergies. And then we're going to watch their kidneys because there's potential there for renal impairment. These can interact with valproic acid. So anyone that's using valproic acid for seizure control, we're going to need to watch them carefully. And we would be really, really careful if that was the case. If there was no other antibiotic that was going to work for them, we would just know that we need to really watch because it increases their risk for seizures. All right, patient teaching for carbapenems, normal stuff, just take all prescribed doses, increase fluid intake, and then of course we'd watch out if they did have history of seizures and they were being controlled by valproic acid. Again, it's probably not the best to keep them on that, but if they did, we'd certainly want to teach about that. Cephalosporins, there's 4 generations of cephalosporins. I do not expect you to know which med is in which generation. Each generation does have the infections that they're more commonly used for, but I'm not too worried about you understanding that. What is good to kind of know is once we get into the 3rd and definitely into the 4th generation, that's when some of those meds can be used for infections that cross the blood-brain barrier, because these meds are able to cross that blood-brain barrier, whereas the 1st and 2nd generation cannot. But again, don't go nuts with all these. Just know that if it begins with Ceph, or whether it's CEF or CEPH, it's a cephalosporin. Our action, these are broad spectrum. We use them for all kinds of infections. They're very, very common medicines. You'll give them all the time. And And again, each generation has kind of their specific indication. And the action, they're bactericidal and bacteriostatic. All right, so adverse effects. These are broad spectrum antibiotics, so we're worried about GI distress, superinfections, colitis. Be careful people with allergies to penicillin. If they have an allergy to penicillin and the doc's ordered a cephalosporin, first thing we need to ask them is, what type of allergy do you have? What happens when you take penicillin? Because every once in a while they'll tell you something like, oh, they got a headache from it, or they, most commonly they'll tell you, oh, I got a little bit of diarrhea from it. It makes my stomach upset, which isn't a true allergy. It's not like we don't just ignore that, but at the same time, it's not an allergy, so we wouldn't really question it. But if they tell you they have a rash or full-on anaphylaxis, of course we would. Those are symptoms of a true allergic reaction, and there's a potential there for a cross allergy between the two, between the cephalosporin and the penicillin. I've read research that says it's high as 15%. So that's significant. We need to make sure we question that. It's not to say that you won't still give them the cephalosporin, but the doc needs to be aware. If it's full-on anaphylaxis, the risk is pretty great to go ahead and give the cephalosporin. If it's a rash, I've seen them a lot of times go ahead with it, but with caution. And you are now on high alert to watch for those things. And sometimes they'll even give them some Benadryl especially prior to their first dose. So just be aware of that. If you're about to hang cephalosporin and they are allergic to penicillin, it's a good idea to call the doc, get a hold of the doc and say, hey, I just want to make sure that we're okay with this, unless the doctor's made their notes about it. But I would still just contact them and say, hey, just to let you know, there's cross allergy potential here because they have a true penicillin allergy. How do you want to proceed? And then document that. I've got a daughter who's allergic to penicillin. She broke out head to toe rash, but has been fine with cephalosporins. We knew we just had to kind of watch her closer, and she's been fine. Again, it's not an absolute. You're definitely going to have a cross allergy to it. However, there is the risk there. Like I said, some research has shown it's as great as a 15% risk. That's a significant enough risk that we need to watch it each time. We'll also be careful in people with renal impairment. It interacts with aminoglycosides we talked about. Oral anticoagulants, it can actually mess with their effectiveness and increase the bleeding. And then the alcohol. With alcohol, it causes something called a disulfiram reaction. And we'll talk about a disulfiram reaction with a few different meds. Disulfiram is spelled DISULFIRAM, disulfiram. What this is it's when you drink alcohol while taking a medicine that has this type of reaction, such as a cephalosporin, it causes these unpleasant symptoms like a throbbing headache, flushing, nausea, and vomiting. People describe it as like a terrible hangover. The problem is and that is a problem. Obviously, you don't want those types of symptoms, and it's also can become worse. It can actually get a little worse than that. So we want to make sure they understand not to drink alcohol while they're on cephalosporins, and not only while they're taking it, but up to 72 hours after. So that'll be a big part of our education. No alcohol while taking cephalosporin, and you cannot drink for up to 72 hours after, because you can still potentially have this disulfiram reaction. Patient teaching. We just talked about no alcohol. So avoid alcohol while taking and up to 72 hours after. Take with food a lot of times to avoid that GI upset. And then the normal stuff. Take all prescribed doses, maybe increase your fluids, those types of things. We may also want to teach them about, watch for, this does cause GI distress, and sometimes it does cause a little diarrhea. But if it becomes frequent diarrhea, that's a concern. We don't want dehydration. And then if it becomes frequent, foul-smelling, very mucousy diarrhea, now we're worried about the potential for colitis or even C. diff. So we will educate them on that as well. Fluoroquinolones, these end in floxacin. So if they end in floxacin, we know it's a fluoroquinolone. Most common one is ciprofloxacin, but you'll see levofloxacin, ofloxacin, moxifloxacin. But ciprofloxacin is probably the most common one you've seen or heard of. These are bacteriostatic, and their indication, they're broad spectrum. We use them to treat all kinds of infections. Urinary tract infections, respiratory infections, GI, bones, skin, all kinds of stuff. Another thing these are used for, especially that ciprofloxacin, is prophylaxis for inhaled anthrax spores. You'll see these anytime somebody's worried about the potential, like, we've all seen the stories where people have mailed anthrax in a terrorist effort. They always go straight to Cipro on those, and it seems like every time there's one of those that occurs, they talk about how there's a shortage of Cipro, and it always boggles my mind and why. But anyways, that's what they always, the news has to sensationalize everything, it seems like. But it is, Cipro is what we go to primarily for those inhaled anthrax spores. Adverse effects. They're broad spectrum, so GI distress and superinfection. But these have some other little nuance or little things that aren't as common with other medications. One is photosensitivity. Now, there are other meds that cause photosensitivity. This is just one of them. And what that means is they need to avoid sunlight, or at least avoid a lot of direct sunlight. It will increase their risk for getting sunburns. So if they do have to go out in the sun, make sure they understand to protect themselves, put on sunscreen, wear clothing that will help protect them, and then not to stay out there for very long while they're on this. Another one that is unique to fluoroquinolones is tendon rupture. There is a risk of tendinitis with these antibiotics. They say it's increased in people over 60. However, I've absolutely seen cases of it occurring in people less than 60. It's also more common when combined with steroids or glucocorticoids. However, I've certainly seen people that were neither over 60 nor were they on a concurrent glucocorticoid, and they still had tendon problems. But that does increase the risk. So what you'll want to do is make sure that they understand to watch for any sort of tendon pain. It most commonly affects the Achilles. Like 90% of the time it affects the Achilles, but it can affect other areas as well. So certainly if they start noticing tendon pain in the back of the leg, but just anywhere where they notice some abnormal pain and it seems kind of in the tendons, that they need to alert their doctor immediately. You may see pain or swelling, inflammation in those areas, and then they can full on rupture, which is, that can be a big problem for somebody. So we'll make sure we understand that with our Cipros, or our floxacins. We're going to watch for that tendon pain. Contraindications. These can also cause some QT prolongation, potentially. So anyone with any sort of cardiac, especially cardiac rhythm abnormalities, we'd be really careful with, if not straight up contraindicated, especially if it's got that QT involvement. Be careful in anyone over 60, of course, for that increased risk of tendon rupture. They say also be careful in people less than 18. It can interact with warfarin and theophylline. We talked about theophylline with the last test. That is the respiratory medication. It causes bronchodilation. But remember, it's a narrow therapeutic range. If you take fluoroquinolones along with theophylline, it actually increases theophylline levels, so they would need to decrease their dose. If afloxacin was the only med available that was going to help them, and they had to be on their theophylline, we would be extraordinarily careful, and the doc would have to watch them very closely, check levels closely, and adjust their dose accordingly. Also can affect warfarin, and it interacts with antacids, iron, and milk products. So you really should wait about 4 hours between afloxacin and antacid, iron, or milk products. It's best practice to wait about 4 hours between, although I've seen some places that say 60 minutes or so. I mean, if your protocol tells you to do what to do, but at the end of the day, it's the best practice seems to be about 4 hours. Patient teaching. Well, we've talked about that. Notify provider of tendon pain. It's very important to make sure that they understand that. It's a low risk, so we don't want to scare them into not taking the medicine. But they do need to understand if they start to have that tendon pain. And that actually can occur up to a year after you've taken the medicine. A lot of times it's dosage and length of treatment. So if they've had a longer length of treatment, they have a higher risk. If they've had higher dosages, they have a higher risk. But it can be up to a year later. Avoid sun exposure, just like we talked about with the photophobia. Photosensitivity, not photophobia. Do not take it with milk, iron, or antacids. They need to wait. Best practices is 4 hours, but you know. And then, of course, the normal stuff. Take all prescribed doses, increase fluids, all that. Penicillin's very common medicine still. There's quite a few bacteria that are no longer affected by them, but we still use them. These were the first ones. Sir Alexander Fleming he developed them, right? He left a window open, some mold flew in, contaminated his petri dish, but he goes, hey, look, bacteria aren't growing anymore. Next thing you know, he wins a Nobel Prize. Amazing. These are bactericidal. Their indication, they're broad spectrum. We use them for a lot of different things, but most commonly streptococcal and pneumococcal infections. So pneumonia, otitis media, sinusitis, those upper respiratory things for sure. We also use them for prophylaxis of endocarditis. These are broad spectrum again, so adverse effects, GI distress, so diarrhea, very common symptom, and superinfection. I just did the adverse effects on the last slide, but I'm going to do them again just so they're on this slide. GI distress, superinfection, again, they're broad spectrum. So C. diff, yeast infections are common in people that take penicillins, so you'll want to warn them about that. Contraindication, again, allergy to cephalosporin. We went through this already. We'll ask them what happens with the allergy. Then we'll contact the doctor and go from there. Cautions. We'll watch kidneys, make sure that they're functioning okay. Interacts with hormonal birth control. It's important for females to know that. I've absolutely heard of penicillin babies before, surprise. So they can interact with hormonal birth control. They'll need to find an additional birth control. They can also interact with tetracyclines. Patient teaching, normal stuff. Take all prescribed doses, increase your fluids. Now your book's going to tell you to take these on an empty stomach with water. The problem with that is these commonly cause GI distress. Augmentin is a penicillin, and if you've ever taken Augmentin before, it says on the label, take with food. So most people actually do take this with food. It potentially can affect absorption, and if they're able to tolerate it, okay, fine. But like something like Augmentin, man, you would definitely tell them to take it with food. but penicillin commonly causes GI distress, especially the amoxicillin. And if you've ever taken it, you know that diarrhea is absolutely a common adverse effect. Now we're going to have to watch that. If it's frequent diarrhea and we're worried about dehydration, that's a big deal. If it becomes that real mucousy, foul-smelling diarrhea, now we're worried about C. diff. So we certainly have to watch that. But again, your book's going to tell you take it on an empty stomach, and that is best for absorption. But man, you'll see in the world when you get out there, a lot of people tolerate it better with a little bit of food. So you go from there. Sulfonamides. These are sulfa antibiotics, another common medicine that people are allergic to. So penicillins and sulfa drugs, those are the most common allergies that you're going to see out there, especially with antibiotics. These are bacterial static. We use these to treat gram negative and gram positive, especially UTIs. That's really what you see these used for a lot nowadays. Adverse effects, GI distress. These also have that photosensitivity potential. And then these are a little higher association of Stevens-Johnson syndrome, so we'll definitely make sure that they understand to watch for a rash. These are contraindicated if they have any noted allergy, any sulfa allergies, thiazide diuretic allergies, even loop diuretic allergies. They'd be contraindicated. Also contraindicated in pregnancy and lactation. Be careful in people with liver or renal dysfunction. Interactions, we talked about them. Oh no, I'm sorry, I'm still stuck on allergies. Sulfonylureas, phenytoin, warfarin. It'll actually increase the effects of warfarin, so it may increase their INR. If they have to be on the 2, that's fine. We just know that they have to watch their INR levels a little closer. Phenytoin, it can increase those levels, so we'll have to watch those closer. Patient teaching, take all prescribed doses, increase fluid intake, so the normal stuff. These we tell them to take on an empty stomach, and of course with the photosensitivity, avoid sun exposure. Tetracyclines, so you got tetracycline, doxycycline. These are bacterial static, and their indication, we use them for a lot of different infections. They're broad spectrum. You'll see these for pneumonia. They're usually a go-to. They're definitely a go-to for Lyme disease, but also chlamydia, acne. We use them sometimes for acne. Adverse effects. They're broad spectrum, so we know already GI distress, superinfection. These, however, can potentially cause some liver damage, so we're going to watch for liver toxicity. And these also cause photosensitivity. And then a different side effect for these that's not common with any other antibiotic is tooth discoloration in children less than 8. So really they're contraindicated in children less than 8 and pregnant women as well, because they can affect the fetus. So that's important to understand. Contraindications, well, of course, pregnancy, just like we talked. Children less than 8. Be real careful, though, in people that already have hepatic impairment. We may cause further impairment. Interacts with hormonal contraception, so they'll have to find alternative contraception if they use birth control. And also milk, calcium, iron supplements, and antacids. Patient teaching. Normal stuff. Take all prescribed doses, increase your fluids. Take these on an empty stomach, and they cannot take these with dairy products, can't take them with antacids. They need to make sure they take them about an hour before a meal. If they have to take them, if they eat the meal first, though, now they need to wait a couple hours. Avoid sun exposure, use additional birth control. Macrolides, these are azithromycin, erythromycin. These are common. You'll hear people or I'm sure maybe plenty of you have been on azithromycin at one point, or you'll hear people talk about a Z-Pak. That's what this is. This is bacterial static and bactericidal. Our indications, we use them again for a variety of infections, but most commonly where I've seen them is respiratory infections. You'll also potentially sometimes see them used for chlamydia. And then when we talked about prophylactic antibiotics for endocarditis, and we said penicillin was the go-to, which it is, but if there's a penicillin allergy, a lot of times they'll go to this as the secondary. Adverse effects, GI distress, they can cause some liver injury, and then also prolonged QT interval. Contraindication, if they've got full-on liver disease, any sort of liver impairment, we're going to be very careful with. Also, if they've got cardiac abnormalities, depending on the extent of that abnormal EKG, we would either be contraindicated or very cautious. Be careful in people that are pregnant or lactating as well. I missed interactions on the last one, but the interactions are, there's actually quite a few interactions, but they can also interact with food. Food will interact the absorption of these medicines, so these ones really should be taken on an empty stomach with a full 8-ounce glass of water, usually about an hour before a meal. If you eat first, then we got to wait a few hours. Patient teaching, take all prescribed doses, and just like I said, take on an empty stomach with a full 8-ounce glass of water, an hour before a meal or 2 to 3 hours after. Vancomycin. This has become more and more common. Back when I first started, it was like, oh my gosh, they're on vanc, they've got a serious infection. And we still use it for serious infections. The problem is serious infections are becoming more common because of the fact that we're more resistant. So you'll see them used for MRSA, C. diff. The action inhibits cell wall synthesis, so they're bactericidal. Again, we already talked about indications, serious infections, MRSA, C. diff. Adverse effects. These have the potential for toxicity, so ototoxicity, nephrotoxicity. So when we know that, then we know we have to watch lab levels. They can also cause infusion reactions, so we will infuse these slowly. These are always infused slowly. They're never infused over or less than an hour, and a lot of times I've infused these over an hour and a half to 2 hours, depending on the dose. Be careful in people with renal impairment or hearing impairment, and it can interact with other ototoxic drugs. Patient teaching, take all prescribed doses. They'll need lab work to monitor levels. Then, of course, increase your fluids. Tuberculosis. We're going to get into this a little bit. As far as the meds are concerned, I don't expect you to know specific. Well, I don't expect you to know the specific regimen. How about that? And it'll make sense here in a second when I talk about it. So it's caused by Mycobacterium tuberculosis. It's a major health issue worldwide, and it's increasing in the U.S. You used not to see it so much in the U.S. Now it is increasing. And it's transmitted by droplets in the air through coughing and sneezing. So these guys are going to need to be in airborne precautions. Our at-risk populations, HIV, AIDS, homelessness, immigrants, and healthcare workers, of course. Here's the meds that we commonly use for this: isoniazid, rifampin. Those two are very common meds for tuberculosis, but also streptomycin, ethanolamide. Again, I don't really expect you to know all of these so much as understanding that it is a multiple drugs that we use. It's not just one of these drugs, it's multiple. First time they use 3 or 4 of these drugs, and then they'll step them down a lot of times. Sometimes maybe they'll give you 3, and if those aren't working, they'll put the 4th one on. But they'll do that for so long, they'll keep watching how you're progressing, your symptoms and your sputum cultures, and then they will sometimes back you off to 2 drugs maybe, and then back you off to 1 drug, those types of things. It all depends on your presentation, if you've had TB before, the type of TB, all of that. So I'm not expecting you to know that. Just understand that it is a process. It's multiple drugs, and you take them for a long time. Active TB, the CDC recommends a phase of 4 antibiotics for 1 to 2 months, followed by a phase of 2 antibiotics for another 4 to 7 months. Latent TB, 1 to 2 antibiotics for 3 to 9 months. Adverse effects. These can cause neuropathy. They can also injure the liver. So we're going to be real careful in people with liver disease. That's our contraindication, and as we know with liver disease, it's always, the level of. Be careful in people with diabetes. Interactions, alcohol, phenytoin. Patient teaching. This is really important with TB drugs. The normal stuff that we know already. Take as prescribed, exactly as prescribed. A lot of times these are taken on an empty stomach, so you'll take them an hour before or 2 hours after your meals. Sometimes people will need observation because these drugs have to be taken specifically and for a certain amount of time. And people are not always compliant because it's hard to stay compliant for 9 months, So sometimes they'll need observation of the medication administration. We'll tell them to avoid alcohol. Tell them to how important it is to make sure they keep their follow-up appointments, because we're going to need to kind of watch them, watch their progression. They're going to need multiple sputum tests. Usually it's 3 sputum tests come back negative before they say that they're over the infection. So that's just really kind of understand the basics of patient teaching. Urinary tract infections. So what are the signs and symptoms of urinary tract infection? The common ones, of course, dysuria or pain with urination. But in urinary frequency, just going all the time, even though it's just a little bit each time, you're just going constantly. Constantly have the urge. So you just went, you just went, but yet you have the urge like you need to go again. Burning sensation on urination, chills, fever, flank pain, tenderness. Now we start getting into that acute pyelonephritis when we start getting those, the fever, the flank pain. Females, of course, are more risk for the shorter urethra. Children may also have frequent urinary tract problems. And then the biggest risk, of course, is indwelling catheters. Nitrofurantoin. This is an antibiotic. This one can be used for acute urinary tract infections. It can cause some discoloration of the urine, so we need to let them know about that. Be careful in people with renal dysfunction. Contraindicated, again, watch out for your urine or your renal dysfunction. Can interact with antacids. Patient teaching, complete full course. Don't take with antacids. You may get that brownish discoloration. Methenamine, this is different. This one is used to prevent infection in those that are at high risk. It doesn't always prevent infection. It just increases the acidity of the urine, making it harder for the bacteria to survive. But it still can happen. They can still have breakthrough infections. Our indication, again, prevention of recurrent UTIs. It's not a treatment for acute infection. So that's our patient teaching. This is not for acute infection. It's just to help prevent recurrent UTIs. Works best when the urine is acidic. So again, this helps increase the acidity. We can also increase our vitamin C intake or drink cranberry juice. That will also help increase the acidity of our urine. And then they'll need to know the signs and symptoms of urinary tract infection to report to their doctor, because again, they can still have breakthrough. Phenazopyridine, also known as pyridium or AZO. You can get this over the counter. All this is an analgesic. It just helps take away some of the pain associated with urinary tract infections. Adverse effect, though, it causes a reddish orange color of the urine. I guess that was here, urinary or adverse effect, that reddish orange color to the urine. Contraindications, again, renal disease, and it's all based on the level of renal disease. Can interact with topical anesthetics. Patient teaching, not for treatment of urinary tract infection. The first thing we need to tell them, look, this does not treat your UTI. You need an antibiotic for that. It's only to relieve pain. And then we'll also tell them, look, it can turn your urine red, orange. In fact, it's very common that happens. And sometimes people think that it's causing bleeding. So they'll just need to be aware of that.